55 and up. We are the partners for the Elder Initiative for these talks with the Elder Initiative. I am going to go ahead and share my screen. Today, we're going to be talking about men's health. And I say this with a little asterisk because we are going to cover some aspects of health that might be relevant to trans folks as well. Can everybody see the screen? Can anybody not? So I want to give some credit today to one of our fellows, Dr. Dana Hovern, who helped me develop some of these slides. She was not able to be here today, but I'm presenting on behalf of both of us. I want folks to feel free to stop me at any point during this with questions, concerns, comments, complaints, whatever. So today we're going to explore a bunch of things. We're going to do some various topics in men's health, focusing on, when I say older adults, I am a geriatrician. Nobody likes that word. When I say older adults, I mean folks who are 55 and older. We're going to spend a good amount of time talking about prostates. So happy Valentine's Day. We're going to talk about prostates. We're going to talk about screening for prostate cancer, why that can be controversial at times. We will talk about anal cancer screening. And I don't need a show of hands necessarily, but I ask you all to think about if that's something you've ever talked about with your provider or if you've ever thought about. We'll talk about the controversy around it. And lastly, because I always do this in every talk, I like to talk a little bit about sexual health and wellness. If anybody has questions, again, stop me at any point. With that said, I want to start by saying that these are kind of the key points. We know that as folks age, prostate cancer or prostate disease risk increases. And we'll talk about what prostate disease means because it's more than just cancer. Prostate enlargement is common in 50% of men over the age of 65. And that is just the prostate enlargement that we can see. If you look with a microscope at the tissue of a prostate, folks who are around my age in my mid-30s start to develop microscopic enlargement. By the time folks are 80, 90% of men will have enlargement of the prostate. So to some degree, this is common and expected, and we'll talk about it. Prostate cancer. Yes, question. So good question. Someone asked, what causes the prostate to enlarge? And I have a very unsatisfying answer to you. We don't know. For all the medical research, yep. And it's not just me. I actually have a specific bullet point on that coming soon. Question being, what causes the prostate to enlarge? We don't know why it enlarges. We'll talk about prostate cancer. It is still the second leading cause of death in men, the first being colorectal cancer. Or as far as cancers, colorectal cancer. Heart disease is still number one overall. We know that changes in sexual response can occur over time. It's important to think about what is considered a normal age-related change versus what is not. And we can really go into some of that and answer questions there. And I want to focus on, in so many talks involving older adults, which I do a lot of these, we talk a lot about problems, disorders, because that's what a lot of what health becomes realistically. But I want to talk about some of the positives around sexual health, how we can keep folks enjoying their sexual activity, having the best experiences they can. So with that said, we will go into the prostate. Now, what is the prostate? The prostate is a small organ that sits basically surrounding the urethra, the tube that urine comes out of. And the prostate helps secrete liquids that are helpful with ejaculation. So it helps to essentially create some of that fluid that comes out during ejaculation. And you see here, these are some angry prostates that have a couple of different problems. The three that we're going to focus on today are prostatitis, benign prostatic hyperplasia, and prostate cancer. Each of those is a little bit different, actually quite a bit different. Of these three, the one that's most important is the largest one, which is in the middle, or the most common, not most important necessarily. Benign prostatic hyperplasia, it defines it by the words. It is growth of the prostate that is not cancerous. It is, I disagree. I did not make this infographic. I wouldn't even call it a tumor necessarily. It is the most common benign growth in men. What that means, not cancer. And we'll talk about what does it mean when we say symptoms are obstructive or irritative. And again, not asking anyone to comment, but those who have had prostate enlargement can probably tell you what some of the symptoms are. On the right, we have the one that can be in many ways the most problematic, which is prostate cancer. Typically asymptomatic. This is the reality of prostate cancer. Despite the fact that prostate cancer is among the leading causes of death in men, the reality of prostate cancer is that many more people have prostate cancer than will ever know it. The other reality is that most people with prostate cancer end up dying of something other than prostate cancer. A couple of reasons for that. One, prostate cancer tends, though not always, grows pretty slowly. Two, our treatments for prostate cancer keep getting better and better and better to the point where now even prostate cancer that has spread outside the prostate to more distant sites like the bone can be controlled for periods of time, even if it can't be cured. The third one that we'll talk about is prostatitis. Prostatitis is an inflammation of the prostate, and it can be caused by a couple of different things, which we'll talk about. And this one can be particularly painful and can cause urinary obstruction. So as I said, BPH is this non-cancerous enlargement. As I said when I was asked earlier, we don't know necessarily why it happens. We know that it occurs with age and it occurs with changes in sex hormones. So levels of testosterone fluctuate normally over the course of life. Levels of other hormones that are relevant in that part of the body also fluctuate. Benign prostatic growth is responsible for an incredible number of office visits and surgical procedures per year. I would say that there is not a clinic day that I can remember in my recent couple of months, and I'm in clinic 4 days a week, where someone has not come in with symptoms that are likely related to prostate growth. And we'll talk about what those symptoms can be. Like I said, why it happens is not completely understood, but what happens we know pretty well. It can result, this prostate growth can obstruct the flow of urine, whether it's complete, which is an emergency, or partial, which can result in things like hesitation or weak stream, or a feeling like you can't completely empty the bladder. It can result because the bladder is now pushing against a tube that is narrowed by an obstruction. It can result in a thickening of the bladder wall. So sometimes when I get imaging on folks who have prostate enlargement, their bladder will look thicker than someone who does not. And because of some of that thickening, it can actually result in decreased capacity of the bladder. So even though the bladder can look larger on imaging, it's the growth of a muscular wall and not the tube that's in, and not the area inside. So decreased capacity. We talked about two different categories of symptoms. And you'll hear if you go to a urologist, they will break these down for you into these two categories. Are they symptoms that cause irritation, or are they symptoms that relate to obstruction? I already covered some of these obstructive symptoms. The irritative symptoms are the things that people often notice first. Going more often, needing to go more urgently, meaning you feel it, gotta go. And urination at night, which you'll sometimes hear us call nocturia. If somebody's asking you about nocturia, they should really try to reframe their language. BPH can definitely affect quality of life, as a couple of different things can happen. One is that as urine doesn't pass as easily, it makes it more easy to get urinary tract infections. As urine sits in the bladder more, It can cause these bladder stones that can sometimes be really painful to pass. It can cause issues with incontinence. As the bladder tries to deal, bladders are good at two things: storing urine and getting it out. When you affect the getting it out part, you affect its ability to store. And the bladder can become really irritated and start emptying outside your own control. Can cause blood in the urine, because if you think about a tube that's being compressed or forcing something through it, you're going to create increased pressure, which can damage the cells in the lining. And especially in cases of full obstruction, you can get kidney issues where the urine backs up. Question? It is. So the question was, is the prostate wrapped around the urinary tube? And the answer is yes. So if you look, I should have pointed this out here, but if you look here, those of us who are here in the room, you can see it here with my laser pointer. This is the urethra. I'm pointing to it on the computer as well. The urethra is the tube that goes from the bladder out. Now, the prostate is here, and it does wrap completely around the urethra. It's a poor design choice, admittedly. Exactly.
Prostate around.
The question is, what sick God wraps the prostate around your urethra? And it is not the best design, admittedly. It's really not. Yeah, especially knowing that the prostate growth happens. So we talked a little bit about this. And now we're not going to go through, this is a big chart, but this is a prostate scale that I encourage everyone to think about, whether you've been diagnosed with prostate enlargement or if you notice that you may have had some of these symptoms that I've mentioned. So first of all, we think about incomplete emptying. How often is that happening? How often are you having to go more often than you used to? How often are you starting and stopping your stream? Are you finding urgency? Are you finding that the stream is weak? Are you straining to try to push out that urine? Getting up at night? And then the last part of this is one that I care a lot about in my field of geriatric medicine, primary care, is quality of life. Sometimes people will have mild prostate enlargement. They'll go a couple extra times a day and they tell me, you know what? I don't want to touch this. I'm fine with it. I can make it to the bathroom. That's one end. The other end of the spectrum is I can't sleep at night because I'm going 7 to 8 times, feel like I have to manually splint. What does that mean? Some people actually have to feel the need to kind of press down on their bladder to get the urine out. There's a very same underlying cause, but very different outcomes. So what do I do about this? First of all, before I think about enlarged prostates, when people come into me with urinary symptoms, I take a look in my chart and I ask the patients, what are the medicines that you're taking? Meaning, are you having symptoms because of a prostate, or are you having urinary symptoms because of a medicine that we may have given you? It happens. If anybody takes Benadryl, this happens with Benadryl, actually. Not prostate enlargement, but urinary stuff. We need to look at whether there are issues with urinary storage versus voiding. Meaning, is it an issue of holding the urine or of getting it out? Issues of storage are often caused by things like overactive bladder. Voiding issues with peeing, are more often issues with the prostate itself. So I'll ask some targeted questions about the experiences you have about peeing. It's a fun time for all. It gets more fun because the next step is often, though not always, a digital rectal exam. That's a finger into the butt for a rectal exam. Now, sometimes you'll find, depending on older docs, so folks who are probably over the age of 55, used to do rectal exams at every primary care visit. Some folks may still experience that. As training changed, when I was in med school about 10 to 12 years ago, the digital rectal exam had fallen out of favor. So almost entirely. Where we're at now is somewhere in the middle, meaning I don't do a rectal exam on every single patient, every single visit, but in somebody who is concerned about especially new symptoms, who isn't already linked up with urology, we will often do that. We'll often check the urine too. So for folks who are able to give us a urine sample in the office, we will look for signs of infection, for blood, for other things that should not be in normal urine, because normal urine should have zero blood in it. From there, you go on to things like advanced testing. And these are things that I'm not doing. These are with a urologist, where they will sometimes do an ultrasound. This I actually have done a few times, admittedly. They put an ultrasound on your bladder and they measure the bladder. Bladders stretch depending on how much urine's in there. And so somebody who has a bladder that is the size of a grapefruit has a lot of urine in there. The average bladder is about that big. And then the more advanced things are flow testing. And again, not asking anyone to necessarily share unless they really feel compelled to. Flow testing often involves some intense contraptions of filling the bladder and watching it empty and filling it again and watching it empty. It can be pretty, not intensive, but it's really good testing for those who want definitive diagnosis. Question?
Could you tell by the color of the urine? Would that be something to be concerned about?
So the question was, can you tell by the color of the urine? And that's not necessarily the case. So unless it's bright red, in which case bright red urine is never normal. The only exception, dark red urine can come from beets sometimes. So if you just ate a lot of beets, your urine turns dark red. See if that clears. So no, good question that I'll take a minute just to talk about urine color. So average urine color ranges somewhere between mid-yellow to clear. Darker yellow is okay. What's not okay is when urine is brown or tea colored. That can be signs of severe dehydration or even small amounts of blood in the urine. Bright red urine is never normal. Dark red urine, as I said, also concerning, unless you just ate a metric hecton of beets. The other, if you ever pass a blood clot in your urine, that is immediate call to the doctor, because that's considered more an emergency. A blood clot. So like a dark, solid piece of material, sometimes if you poke at it, it'll break apart. Definitely not something that we want to mess around with and leave lying in there. I think somebody's trying to get in here. Oh, or maybe not, or running away. We scared them away. Bladder stones. So the question is, what is a bladder stone? So sometimes as people's urine sits in the bladder, all urine contains certain chemicals and certain electrolytes that if it just sits there and sits there and sits there, these components of natural urine can start to crystallize and they form what looks like a little stone. They're not as common as kidney stones, let's say, but they are similar. Yes. Correct. If urine is flowing, less likely to get bladder stones. Another question.
Just as you would see a dermatologist or some specialist, because your GP doesn't feel comfortable with that skill set. At what point do you say, yeah, I'm going to go see a urologist?
Yeah.
Instead of a GP?
So this is a great question. And the question is, at what point do you want to see a urologist instead of your GP or primary care doc, depending on levels of comfort? So one, if you feel that so first of all, if you're complaining of these symptoms or if you're having concerns about symptoms and not getting a rectal exam, number one. Number two, if you're getting these symptoms and your doc checks a lab and says everything is okay, that's fine. That's not necessarily the case. Three, if you feel that thing, primary care can manage the initial workup of prostate growth. At least many can. You'll find that the comfort level does vary. So the third part, and I know this is kind of a whiff of an answer, is if you're getting the sense that things aren't working out the way you wanted, or if your symptoms aren't improving, that's the time.
Do you see a dermatologist for annual skin cancer check?
Yep.
Would you ever see just going to a urologist?
So question is, is there a point to seeing a urologist for an annual check? Some people do. Definitely. I have patients that have done this for years. I generally, for my patients, I wouldn't necessarily recommend that because I feel comfortable talking to my patients about this and assessing for urinary symptoms. I leave that up to patient choice and if they feel their symptoms are being addressed. Another question.
I had
Sorry.
a frequent. I had a Euro.
Mm-hmm.
I only really get up once,
Yeah.
but. And then again, it's much better, but I still do have the frequency thing sometimes during the day.
Yeah.
And I don't think I'm having trouble. I mean, what I've noticed is you drink coffee, or
Mhm.
soda, or foods, your flow is just.
Yep. So people, it's more of a statement too, where there are a lot of different causes of urinary frequency. And so one of the comments that was just made was, well, I had a urolift, let's say. So urolift helps reposition the internal organs to keep things flowing as they should, not necessarily related to prostate. Two, sometimes, a lot of times when I see people and, we do a rectal exam, we check a prostate test, which I'll talk about in a few minutes, and everything seems normal. I then, you get into some history with folks and you find out that, hey, I drink 14 cups of coffee per day. Well, coffee's a bladder irritant. Coffee causes the bladder to contract. So frequency can be caused by that too. And I'm not making up the 14 cups of coffee. Somebody told me that just earlier this week, and I was like, I would die. It doesn't shrink the bladder, it irritates it. So the coffee essentially causes the bladder to squeeze. So it makes, yeah. So in addition to making you produce more urine, because coffee is a natural diuretic, it also causes the bladder to want to get rid of that urine. There you go. Question.
Two questions. One about coffee. Is decaf coffee any different than regular coffee?
So good question. Is decaf coffee any different than regular coffee? Yes and no. Part of it is, so the caffeine in coffee is the major diuretic effect. So decaf coffee has 95% less caffeine than regular coffee. So that part will be better. Parts of coffee are going to be even, so parts of the coffee bean itself can cause the bladder irritation. So it's not perfect, but it can be better. Did you have a second?
Yeah. Jefferson, before the pandemic, was doing a digital rectal exam study.
Yes.
Whatever happened to it?
It's a good question. So there was a question about Jefferson doing a digital rectal exam study. I'll need to look into that, and please remind me at our next talk to get back to you on that, because I remember seeing ads for that too. And so many things fell apart in the pandemic. I don't know if that was one of them. Sort of. Coffee, question about what coffee is good for versus bad for. It's sort of like red wine. Every year they change their mind on whether coffee is going to help you or kill you. I would say it's somewhere in the middle. Question.
The same thing applied to tea.
Tea to a lesser degree than coffee, just because the caffeine content is so much lower generally. The only exception being matcha, which is a longer acting caffeine. Question.
I had getting up at night.
Mhm.
I stopped drinking anything, and particularly eating foods that have a lot of water.
Yeah.
Not a drop, and now how much is that?
So the question is, at what point does the timing of how we drink throughout the day affect urination at night? It definitely does. Generally, we recommend, or I recommend, no minimal drinks within 2 hours of bedtime if you're having issues at night, at least as a trial. Because these are, like we were saying, these are all things that in the workup for, is this prostate, is this something else? As we're getting these tests, I'll often say, hey, let's try not drinking coffee after 2 p.m. because that affects it. Not drinking anything within 2 hours of going to bed. Trying to avoid caffeine later in the afternoon of any type. So everything. There's so many things that have caffeine these days. Question. Saw palmetto. We're going to get to that. We're going to get to it. All right. So treating benign prostatic hypertrophy. The most common thing that people are going to do is lifestyle changes. So whether your urinary symptoms are caused by the prostate or not, the things that we were just talking about, bladder irritants, alcohol does it too. Alcohol irritates the bladder, makes it want to empty. Nicotine does. Trying to minimize how much of that we're doing, especially later in the day. We're looking at, these are often things that can affect symptoms enough to the point where medicines or surgery are not necessary. Medicines, I'm not going to go through all of these, but basically there are a lot of different categories of medicines. Some of you may recognize medicines like Flomax or Tamsulosin, finasteride, tadalafil, also known as Cialis, usually thought of in a different way. For men who have trouble with both erectile dysfunction and bladder issues, tadalafil is really good because it's a 2-in-1, and I love 2-in-1 medicines. Now, sorry, this is not diagnosing an enlarged prostate. This is treating an enlarged prostate with surgical outcomes. Surgery is often considered a last resort, whether that's because on the surgeon's end or on an individual's end. The most common approach is via the urethra, called a transurethral resection. And this is a little image of kind of what that looks like. So as you can see in this image, the prostate does completely surround the urethra. Now, it looks, I see some people's faces as I talk about this. It looks intense. We're not going to go too much on it, but it's essentially a guide wire that scoops out part of the prostate. And that's all I think the detail we need to go into. We need to be thinking about what are the outcomes of prostate surgery. Now, there are like 20 different ways to do this. This is the most common one. The things that we worry about with prostate surgery, anytime we're messing with, because the prostate is involved in the ejaculation process, there can be some level of erectile dysfunction if we have to do surgery. What's that? Yes. So somebody had a question about that. There can be some level of erectile dysfunction with this. The other thing that there can be is some level of incontinence, because ideally, in an ideal world, we don't mess with anything that opens and closes. So anything that's called a sphincter, we try not to touch. When you are going into a tube and scooping things out, you are essentially messing with natural plumbing. In this case, it's for a good reason. We're not just doing this willy-nilly, but there is some risk of incontinence. That said, we're getting better at this. Question?
Not an erectile problem, but a ejaculation problem.
Mm-hmm. Yes. So that's another good question. Can you see not an erectile problem, but an ejaculation problem? Sometimes people who have these surgeries will notice things called retrograde ejaculations, where instead of the liquid going forward, it goes back into the bladder. We're going to talk more about that. Sometimes people will notice that the volume of the ejaculate, so the fluid that comes out, is less. The question is my bladder having a good time when my partner is not? Possibly. So prostates can get big. Now, this big dark thing that you see here is a bladder. That is probably the size of a slightly deflated volleyball, and that is blocked by the prostate. This is an emergency. If you cannot pee, it is an emergency. I had to deal with a family member calling me recently, and I was like, hey, that is an emergency. It can be caused by a lot of things, whether it's the disease progression, whether it's a surgical procedure and a change in anatomy, less common, whether it's an infection. This needs to be decompressed very quickly with a catheter. Nobody likes it, but also this is extremely painful. I want to go on a little bit and just do brief talk on prostatitis. Anyone who has had a bout of prostatitis will never forget it because it is hard to fix. Takes a long time, 3 to 5 months. Can be either bacterial or non-bacterial. Most commonly, our favorites, E. coli, gonorrhea, chlamydia. Now, more common in younger men, and they say this because honestly, we have better data on younger men because older folks are not as frequently studied with sex. It's true. Symptoms, fever, chills, pain can require long course of antibiotics and nothing in the rectum, which can really affect people's sex lives. So if you are noticing these symptoms of fever, chills, pain when you pee, burning, and especially if your urine is coming back clean when the doctor checks you, that's the point where I start to think about doing a rectal exam. Because for a rectal exam in a patient with prostatitis, it is extremely painful to touch to even come near the prostate. And if we catch it early, we can get you on a shorter course of antibiotics rather than needing to be on it for 3 to 5 months. Prostatitis, far less common than the benign stuff we've been talking about, something to be aware of. Prostate cancer. We're going to be done with prostate soon. I'm sorry. I feel like I've said that word like 50 times. Most common non-skin cancer, more common as people age. We said that people who have a first-degree relative, parent, sibling, child, are more than twice as likely to develop it. A history of a sexually transmitted infection affecting the penis does increase risk, or is thought to increase risk. Now, screening for prostate cancer. This is another great area of controversy. There have been wildly swinging thoughts on this blood test called the PSA, or prostate-specific antigen. This is something that is released by the prostate normally. Everyone has a PSA, a certain amount of PSA floating around in their blood. Larger prostates release more. The problem is that larger prostates can be caused by a bunch of different things, including the benign stuff. PSA testing, a high PSA, does not necessarily mean prostate cancer. So that's part one. It's not a very specific test. So sometimes we're sending people down this pathway of getting some, maybe even a biopsy if it's high enough. And it's like, it's not cancer. Good news, but still. There's also the concern about overdiagnosis, meaning if I screen someone, what if I find that prostate cancer that's just sitting there and is never going to bother you? And some people ask, well, why does that matter? I have a colleague that talked to a patient recently, and the patient was like, no, I want to know, I want to know. Ended up finding the tiniest prostate cancer, getting a surgery, and developing inability to get an erection. And so that person was like, well, I should have listened to you. As we said, most men die with prostate cancer, not of it. Question.
My father died of prostate. What did he die?
So I'm not saying no one dies of prostate cancer. I'm not. My grandfather died of prostate cancer. Most men who have it, it's like a significant majority, end up dying of something like heart disease, stroke, one of the other many medical problems that people accumulate. Not necessarily. It can make you more physically frail and less able to, it can affect immune system. It can affect. Maybe I can't speak to that one in particular. In my grandfather's situation, he ended up developing widespread disease that spread to other areas. So that was what ended up resulting in him dying. It's hard to, I don't want to say no one dies of prostate cancer. People do, but can the prostate cancer spread? It can. And so we are going to talk about that actually. Diagnosing prostate cancer, same process, honestly. The PSA test, we said, is not specific. The digital rectal exam, if the prostate feels hard or nodular, that can be concerning. But again, we will find both false positives, meaning I might feel a prostate and think, oh, that's really concerning, get a biopsy and it's not. We might get a PSA that's low and somebody that ends up developing prostate cancer. These are not perfect tests. And that's why I have a discussion with every patient before, there are certain things that I order on everyone. Cholesterol testing, let's say. I order that. I say, hey, my standard battery of tests includes X, Y, Z. I always put a special little star in my head next to prostate cancer. I don't just order it without telling anyone, because this can have significant impacts on what's next. Now, treating prostate cancer, bunch of different ways to treat it. For some people who have it very mild, we can watch it and wait. For others, you remove the prostate. For still others, there is radiation as an option. And radiation has gotten so much better over the years in that this is a very wide beam of radiation here that you see on this. And radiation has gotten much more targeted. Question out there.
My brother had prostate,
Yes.
but the cancer came back. I went with radiation and I'm cancer free. And now he's on the pill and he takes shots.
Mm-hmm.
He's doing good on that regimen because the levels are coming down. But I thought when you have it possibly removed, the cancer couldn't come back.
Yeah. So there's a question about if the prostate is removed, essentially, how can cancer recur? And this is where cancer gets really, this is a bigger cancer discussion. Cancer is really sneaky. All that it takes is a very small amount of cancer cells left behind. So that's why when they take the prostate out, they even take out where the semen comes from, the seminal vesicle or the tube. The goal is to get every last little piece of it. But if you think about anyone who's ever seen surgery has known that even if you take something out in its whole, in its entirety, there are maybe microscopic pieces of things that we just are not able to see. That medicine, as good as we get, that there might be a lymph node that's hiding just down the line where the prostate cancer is spread to that we don't know about. And so that's often where we start to see things coming back. So I don't want to, yes.
Will the erectile function ever come back?
So will erectile function ever come back when we're thinking about prostatectomy especially, or in some cases medicines? The tough part about treating prostate cancer is actually that a lot of the medicines we use to treat it can suppress the male hormones. So Lupron is a common example. When folks are on Lupron, which is a male hormone receptor antagonist, meaning it blocks the male hormone receptors from working. That's what it does. It makes the prostate shrink by cutting off its hormone supply. It's really hard to regain natural erectile function while on that medication, let's say. And I want to be clear, I'm not encouraging people to go off their medicines. In the cases of prostatectomy, it can also be pretty difficult for things to come back naturally. So that might be where we start talking about needing some treatments for erectile dysfunction, which is the next part. So I want to move on from the prostate because I'm tired of prostates. I want to do one slide on anal cancer screening. And I'm going to guess, and again, you don't need to tell me, that most folks in this room have not been offered anal cancer screening. We know based on evidence that men having sex with other men who have rectal HPV virus, so genital warts, it can be in the rectum too, can be up to 17 times more likely to have anal cancer. There is a way of screening for anal cancer called an anal pap or anal cytology. It is done in a way very similar to the way I would do a pap on a cervix, where I insert a swab into the rectum, make 2 or 3 swabs around, dip it in a medium, and send it to the lab. Now, the big guideline groups from the US government to the Centers for Disease Control have not been able to decide if this is a useful test for the general population. By that, I mean for general men having sex with men who are not living with HIV. For folks who are living with HIV, it has been very well documented that many folks with HIV may be at higher risk of having HPV in the rectum, even if they don't know about it. Folks who have HIV do benefit from anal cancer screening. So again, if anyone out there is living with HIV, should discuss with their doctor the idea of getting an anal cytology. It is a very quick test and it can be really helpful. The latest trials have said that this can really reduce the risk of developing anal cancer. Question?
More like, sometimes more like, also anal sex.
Not because of the anal sex, because any type of sexual contact increases the risk of developing HPV or those warts. It's not necessary, you know, there has been some studies about does the microtrauma of rectal insertive sex, does that affect the tissue? Maybe a little, but not as much as the HPV risk. HPV is so widespread now in the population that's the thing that we're more worried about as opposed to just the anal sex.
You're on HIV control drugs. That helps.
If you're on HIV controlling drugs, does that help prevent? It lowers the risk, but not completely. There is still thought to be some level of immunosuppression. So the recommendation, New York State was the first one to say this, and there was a big trial done last year. New York State says we should be thinking about doing this at least yearly anyway, even if folks are controlled.
Screening for HPV versus screening for cancer.
So that's a great question. It screens for both at the same time. What it does, just like a pap smear for a cervix, is when I swab that Q-tip around, I'm getting cells. I send that to the lab, and the lab is looking for what we call atypical or abnormal cells and testing for HPV at the same time. And the result, what we find from that, determines if and when we need to do the test again.
One or the other for both.
Correct. And so, you know, what happens if you get a positive test is the question. What they will often do is I then get our colorectal surgeons involved, and they do what's called a high resolution anoscopy. They put essentially a small metal scope into the rectum and look at the cells of the rectum under a microscope from the outside. Question?
Would you see your neurologist for that or your primary care doctor?
This would be primary care generally. Yeah. Question? So the question is having genital warts in another part a consideration in this? Not necessarily. It would still warrant screening. And, you know, there are folks, I talk about this with my patients, even who are not living with HIV. I discuss that the test is not perfect, that we don't really have evidence. I at least offer it to folks. I think it's reasonable to think about if it's something you're worried about. Hopefully I haven't just planted that worry. All right, sexual function and dysfunction. Erectile dysfunction. I don't need to define this for folks. This is, if you've ever seen a television commercial, you have seen an ad for erectile dysfunction, often with usually two straight people in bathtubs on a beach. A lot of different causes of erectile dysfunction. Stress, performance anxiety, depression, these can all affect erectile function. As folks age, we may develop certain medical conditions that can also affect. Things like changes in the blood vessels are called atherosclerosis, high blood pressure, diabetes. These are all things, you know, when I see patients who are telling me, I cannot get an erection, and then I look at their average blood sugars and they're running in the 300s. That is probably one of the major reasons. We can improve erectile function to some degree by managing some of those underlying conditions, by getting the blood pressure down, by controlling diabetes, by making sure folks are on the appropriate medicine regimens and lifestyle changes. Now, extremely common to some degree, up to 70% of men by age 70. It's important for me too to be looking at medicines that can cause erectile dysfunction. Most common ones are called beta blockers. Medicines like metoprolol can cause erectile dysfunction, especially at higher doses. Doesn't mean we stop them. Please don't stop your medicines. But it means that we may need to make adjustments or consider alternatives depending on how much that's affecting quality of life. We have a ton of treatment options. There are medications that can be taken by mouth, sildenafil or Viagra, which is kind of an as-needed thing, 30 minutes before sex, versus tadalafil or Cialis. There are some folks, Cialis works longer. So some people will take it once a day at a very low dose in case they want to be ready. That's what all the commercials promote. Some people take it and can be ready for, it works for between 8 and 12 hours. For some people, including some of my patients, that may not be enough. Some folks who have the stomach for this will consider injectable medicines. They go directly into a part of the penis called the cavernosa to help promote blood flow into that area. Not for everyone, because many people don't want to think about that. Vacuum pumps, surgery. There are implants that can be placed into the penis where one of the testes can be replaced with essentially a pump. And so it can be used to help pump up the penis. That works for the erection, not necessarily for ejaculation. Other sexual issues, couple of things that just I want to touch on. Premature ejaculation, it's in the name, it's ejaculating too early, can affect 20 to 30% of men. There are a variety of techniques for training called the start-stop technique, where essentially, some might also call it edging essentially, where you're essentially starting, getting close to ejaculating and stopping and doing that multiple times in order to train. SSRIs, antidepressants. Antidepressants cause this in many cases, whether we want to. They cause delayed ejaculation, whether we want them to or not. In certain cases, I have put people on those medicines specifically because they are ejaculating too early. There are topical anesthetics that can be used to help numb the area and treating underlying erectile dysfunction. We already talked a little bit about retrograde ejaculation. Last comment I want to make about that is that it is not a serious health issue by itself. It can be a little disconcerting when things go the wrong way. Some people will notice a feeling and panic. It is not an emergency. I just want to be clear on that. So I wish that we had more time to talk about this. I'm happy to bring it up next time. What about testosterone? I get asked this all the time. If I go on Instagram right now, I guarantee you after this talk, I will find an ad for a clinic that will sell me testosterone right now. I have people who come to me having visited those clinics where if you sneeze, you will get testosterone. If you feel a little bit tired, you will get testosterone. And I am not saying I'm opposed to testosterone therapy. I am not. But it has to be reserved for situations of what we call true hypogonadism. Meaning, have we actually done a workup? Fatigue is caused by about 50 million different things. Somebody comes in, they tell me I'm tired. I can order 20 labs without even blinking an eye. Some of those might involve testosterone. Some of those might involve sex hormones. We should do that before just throwing someone on testosterone. There are a lot of ways to administer T via patches. It's easy to get. But there are real side effects that we need to look for. Changes in blood counts. It increases the red cell count. It can cause the prostate to enlarge. Not always great. In folks who might have some degree of heart failure, and even in those who don't, it can cause fluid retention. So I'm not saying no testosterone ever. I think there are certain folks who really benefit from it, but do it in a way where do it with someone you trust, first of all. Don't go buying it offline, especially from some sketchy websites. But really being thoughtful, I encourage you to talk to a doctor or a provider who you trust and know before you think about it. Question.
Now, normally our body builds up our testosterone.
Yes.
But what about the guys that go to the gym that want this bulk body and they take those measurements that have it in the formula?
Yeah.
Doesn't that harm the body?
Oh, yeah. So the question is about people who are taking those supplements that or steroids essentially that include testosterone. Are those harmful? Yes. The combination of things that are in those, sometimes there's testosterone in there. Sometimes there is growth hormone. Sometimes there are other hormones that actually can affect sexual function negatively. They're combining those can lead to significant cardiovascular risk. And that was one of the things that was people worried about for a long time with T itself, is the fear that testosterone is going to cause heart attack or stroke. Data on that's not perfect. Am I going to give it to someone who's having active chest pain and can't walk up a flight of stairs without having chest pain? No. But especially when combined with some of those other sketchy hormones that are all mixed together, bad news bears. No pun intended. Hypogonadism is a lack of natural sex hormones. Testosterone, DHEA, it's the long one. There are a bunch of different hormones. And so in some folks, the levels decline with age naturally. In some folks, more abruptly than others.
DHA okay to take?
With limits. So yes, case by case, I'm not saying no. It's not going to be as helpful as most people think it is, though. Is DHEA okay to take? All right, last thing, STI prevention. It's not a talk that I give without talking about STIs. Hate them, don't love them. Older adults, we don't talk about sex. Meaning we, I mean my field of medicine. I talk about it all the time with people. Older adults are less likely to use protection, less likely to be tested because we're not asking people. Screenings for men having sex with men are done based on risk. If someone is consistent with a partner, with a single partner, if someone says they use condoms 100% of the time and never forgets, even when they're with different partners, I'll offer it every time, but I'm not gonna push people. If people say they use condoms 75% of the time and they are having sex with new partners, we should be testing. And we should be doing site-specific testing. What does that mean? That means, there's a very easy way to test for gonorrhea and chlamydia in the urine. That's easy. Drop urine, done. But if people are having oral sex, if people are having anal sex, gonorrhea and chlamydia can hang out in those areas. So if your doctor has not offered you testing in those areas, ask them, please. I also like to bring up PrEP. No one is too old to be on PrEP. PrEP is pre-exposure prophylaxis against HIV. PrEP works. Taken every day, it can reduce the risk of HIV infection by up to 99%. So here, officially, the CDC says men having sex with men who've had an STI in the past 6 months or have had a condom, sex without a condom, should be using it. I offer it to anyone who is having unprotected sex with new partners. 3 options. Well, more are coming, but 3 main options. 2 are oral, 1 are injectable. Talk to your doctor about what's right for you. Insurance coverage is improving.
And even if you want PrEP, you still should have protection.
Yes, I agree. I will say PrEP protects against HIV in 99% of the times. It does not protect against gonorrhea, chlamydia, syphilis, HSV, herpes, or a lot of other things. That's it. We do have something that can be, this is new kid on the block. It's called DoxyPEP, Doxy post-exposure prophylaxis. This is huge. I love this. I give it out like candy. Morning after regimen to prevent sexually transmitted infections that are not HIV. Ideally within 24 hours. If you are not allergic to doxycycline, this is something where if you are having unprotected sex, you should consider having this in your bedside. CDC guidelines are coming, but the early studies, and these aren't really early, these are big trials that show promise in reducing risk of gonorrhea, chlamydia, and syphilis. This is amazing. I love this. A lot of people in medicine are not doing this yet because honestly, not everyone reads up on this stuff. This is not just me being 1, cocky, or 2, going off the rails. This is something that the Infectious Disease Society of America is on board with. This is something that I think we're going to start seeing more and more of in the coming years. Doxycycline as needed. DoxyPrep. DoxyPEP, actually. DoxyPrep, you mean pre. Not studied yet. Coming.
Now, this particular prescription, is that over the counter?
It's not. It's a prescription because it is an antibiotic. So we can't just, we have to be really cautious in general with antibiotics. This is one where I am willing to give antibiotics in order to prevent longer courses of worse antibiotics, essentially. But yes, it is a prescription. Sorry, I'm flying here because I have to get to clinic. I want to end with just another plug for Pride at Center for Healthy Aging. We see folks 55 plus. We do HIV and aging. We do gender affirming care, sexual health and wellness, primary care. We are within the Center for Healthy Aging, which is a SAGE certified practice. We have everyone in our practice trained in affirming language, inclusive decor. We're trying to really not just hang up a flag and say, hey, We're cool. We're great. We love gay people. We are actually trying to do good work here. And I think we're succeeding so far. So that's our number for referrals. That is from our ribbon cutting. Thank you for those who attended. And thanks a lot, guys. Sorry, I ran a little over.
Thank you.
Hey, it's really nice to see everybody here. We're gonna, next month, we meet every month, on the second, Wednesday at noon, normally in this room here. Next month, however, is, older women's health. So, not sure if you guys are gonna be interested in that, but please tell any women that you know, that it's gonna take place, because as you can see, Dr. Danielewicz is really, good what he does. And, so thanks so much for coming.
Thank you.